Greetings from SR Academy. I'm Dr. Akash, orthopedic spine surgeon. Today we'll be discussing step-by-step guide for percutaneous pedicle screw. The principles will be used in vertebroplasty as well as vertebral biopsies also. To have a very concrete base, we discuss only the X-ray based technique. So the principles will remain same even in robotics as well as navigation based pedicle screw fixation. So to begin with, you should be comfortable with anesthesia. Like if it is a vertebroplasty or a biopsy, you can go with the sedation and MAC type of anesthesia. If it is a fixation, it's better to go with the general anesthesia. Position, like as all of you are familiar, the abdomen should be free and proper padding for the chest as well as the pelvic bolsters. Make sure before draping, the movement of CM is comfortable and your technician is familiar with the surgery and the levels what you're planning. Lead apron, preferably to wear a thin lead apron, which is lightweight. So because a lot of radiation compared to other procedures, as it is a mostly image-based procedure. So even the assisting staff should be familiar with the instruments. So we'll be discussing about the index case here. It's a 48-year-old female, far from height, intact neurology, but Telix score was 5, though the MRI appears very stable. On the STER image, there is involvement of posterior ligamentous complex. So we plan for a stabilization. So this is how patient was positioned, adequate draping. Uh, it's based on your comfort, whether you will be using a frame or a silicone hood. Strap the patient well, because in this image, sometimes when there are vertebrae is not squared, when you want to tilt the table, that time the strapping will definitely help. So up to 15 to 20 degrees of tilting table will be possible if you strap the patient well. Mark the same C-arm levels on the floor, and there should not be any hindrance for the movement of the C-arm to get a good image. So floor marking help in both ways, like it will help in the quicker surgery and less load of radiation to the patient as well as the surgeon. Note the KV for both AP and lateral because it will change in both. So this is something called squaring of vertebra. This is an AP view of X-ray. You can see this uh, vertebra where there is a fracture. So spinous process is not centrally placed and the facet and pedicles are not symmetrical on the other side. So this can be squared either with tilting the table or tilting the C-arm. Recommendation would be tilting the table because every vertebra changing or remembering tilt the C-arm tilt will be very difficult. Once the table is tilted, you can see the central spinous process as well as a uh, symmetrically placed pedicles. So this is for the lateral view. So to get a good squared vertebra of interest, the end plates should appear parallel, single straight line. So when you get a proper squared vertebra, the end plates appear as a single line. So this is very important in especially a degenerative scoliosis. Each vertebra, the CM position will change for squaring. So drape well, avoid IOBAN over the surgical site so that the microplastic doesn't enter the surgical field. So for entry, always prefer a 3.5 dimension of Jemshedi needle, because if there is a wrong trajectory, you have still some scope for readjustment or re-entry. When you take a larger entry, always the Jemshedi will again go back to the same point. So we have got different sizes based on the length. It can be 10 centimeter and 15 centimeter based on the patient size. Like obese patients, you can go up to 15 centimeters. So this after draping, usually you can place a gauze around so that you can avoid the direct radiation closer to the patient. You can stand away once you place the long guide wires or K wires. So this helps to locate the entry points. So with multiple horizontal K wire or guide wire, you can take the and mark the entry for multiple vertebra. This artery I have placed just to confirm or be aware that the which side is right and which side is left. So this gauze will prevent the rolling of these guide wires. If you please place directly on the trip, chance of them rolling or misplacing is very high. So once it is marked, infiltrate the entry points with zero point 0.5 lignocaine with adrenaline. So always make sure you mark the midline as well as the entry points so that before taking entry, you will know is it symmetrical, is it proper in comparing with the other side. So entry usually 1 centimeter from the lateral part of the pedicle based on the X-ray. If it is a thin patient, if it's a very obese patient, and if you want, if your angulation has to be more, then up to 2 centimeter you can go. Avoid marking both incision close to the midline because sometimes once you insert a J needle on the other side, when you start angulating, the previously inserted J needle will move because of the stretching of the skin. So plan your incision wisely before taking an incision. Secure the 11 size blade so that some patients there is a chance that it can get entrapped in the fascia. So you have to go till the deep fascia, make us opening in the deep fascia. If sometimes if it is patients are very thin, you can hit the facet also. So be familiar with the length of the instrument. All the instruments are well calibrated. So you need not worry or take repeated shoots. You can go up to zero point 0.5 to 1 centimeter under the length based calculation. So you can compare the adjacent level also. So you know how deep you are going. So this is the main important slide for today's discussion. So once you are entering, the red left mark shows the entry level. When you are in the lateral view at the on the facet, your point in AP view should be away from the midline, lateral to the pedicle. So once you reach the midpoint of the pedicle, so you should not have crossed the midpoint of the pedicle in AP view. Once you reach the pedicle and vertebral body junction, that time it should be just touching the medial part of the pedicle in AP view. Once you are deep, almost 70 to 80% into the body, it should be beyond the pedicle, not crossing the midline. So these are the points. This is a very basic slide, a basic principle slide, which we should be very familiar with. So here we have got a similar case where the already the guide wires have been positioned for above and below level. We are doing an index screw fixation. So you can see the entry point red away from the lateral part of the pedicle. So then green, you have entered to the mid part of the pedicle, but you are still just short of the middle of the pedicle in AP view. In AP view. So in the third position, you have reached the pedicle as well as pedicle vertebral junction. That time you should be just at the medial border of the pedicle in AP view. This is a very principle for which should be very commonly used, and this take a few more radiation exposure. So if in doubt, if you have put two J needles simultaneously, then to know which has gone ahead or which is short, you can remove the still length inside the J needle. Then you'll be able to know identify the cannulated J needle based on the for the comparison. So guidewire insertion always you should feel the bone anteriorly. So if you're not feeling the bone anteriorly, it means that there's a anterior breach or there's a lateral pedicle breach. So sometimes we hesitate for angulation. So when you see compare this, almost 70% of the vertebral body it has gone in lateral view, but here it has not gone beyond the medial body. So this is acting too safe, and there's a chance of pull out, and it is less hold compared to the this type of J needle insertion or the entry. So where still you have 20 to 30% entry only, you need not angulate more, but you have got a better reach, better angulation in this, the lower one. So good entry, no further angulation, you have to go straight. These two entries should not cross the midline. So while removing the J needle, after inserting the guide wire, make sure you rest the elbow on the patient, and the jog of repeated rotation movement, you have to pull the J needle, keeping the guide wire in position. The always check a CM view, keep the CM the lateral direction so that the guide wire neither should go front or get pulled off. So once the all the J needles are removed, you have to secure the guide wires for the with arteries. So if you're planning for a MI stay leaf, the side which you're planning, screw should not be inserted because cage insertion and uh, tubes insertion will be difficult if you insert the screws. Once their guide wires are secured into the bone, change the uh, like instrument to the tap. Always use a tap sleeve. You go with the one size lesser tap. While tapping, make sure the guide wire is not pushed beyond. The length of the guide wire should be well maintained. Sometimes the guide wire may bend at the tip of the screw while insertion. So once your screw has crossed beyond the pedicle and body junction, you can retract or pull the guide wire a bit so that the guide wire won't get stuck in the body. So this is how it looks after insertion of the screws along with the screw holder, and this is the skin incision. So if you're planning for a extension, because the guide wire and the junction entry were zero point 0.5 or maximum 1 centimeter incision would have taken, for the extenders of the screw you need at least 2 centimeter. So if you're not planning for a T-lift, then preferably take an incision away from the sides, like midline with respect to the screws, so that the skin extension won't meet at each other. So rod incision can be measured with using the rod length gauge in single level case, but it is eyeballing in multi-level. Usually it is for one level it is 40 to 45, for its two level approximately around plus 30 plus 30 each. While insertion, check for both AP and lateral, and once inside, use the checking device to confirm the table, uh, confirm the rod, whether it is into the tooling. So Don't detach the rod holder till the final tightening. So once it is tightened and you have confirmed with the rod checking device, then you can remove, because once you remove, you won't have any access or control to turn or pull or remove the rod. So ideally the adequate rod length should be 5 mm beyond the tulip, proximal as well as last distal one. So these two are the decent screws, the similar to the previous one, though it has gone to 80%, just it is grazing the medial wall in the AP view. They are inside, the hold was good, but when you see the lowermost screws, these are the good screws. You are around 70 to 80%. The screws on AP view has gone around 5 to 6 mm. So this is a decent angulation and a well positioned screws. The lower one are well positioned. Uh, these are okay, not that great. So this is how the skin incision for away one. So this case had an issue, like we had taken a two entry very close by. So after we noticed that the Jemshedi needle were being pulled because of skin traction, we had to take a lateral re-entry. Thank you very much.